is Khang from University Medical Center at Ho Chi Minh City, Vietnam. And this afternoon, I will have a great pleasure to be here to share with you about one clinical case upon botulinum toxin injections for cervical dystonia. And I think this case will about the discussion case, and therefore I will have some questions for all of you in this audience to prepare for my questions. Because previously, Dr. Tai will have a great presentation about the type of cervical dystonia and muscle selection. Therefore, I think I hope that all of you will join with me in this case. And my outline for this presentation, we have the three parts. First of all, about my clinical case, and next I will describe some strategies for the application of the botulinum toxin injection for cervical dystonia. And finally, we have some notes for my conclusion remarks. And first of all, I will start my case. This case about a 26-year-old male who admitted to our department because of his abnormal movement at his neck. He just have only 6 months before admit to our hospital. He has started to feel the abnormal movement at his neck. At first time, just a tension feeling about at his behind of the neck, and after that, these abnormal movement progressed day by day. He also used some medication and take the rehabilitation, but those abnormal movement did not improve. These abnormal movement make him difficulty in daily activity and this stop him from getting communication with the other people. Before he has these abnormal movement, he denied using any medication and no family history disease previously. And you will see in this video, this is the first time that the patient take the examination at our department. And you will see that he has some abnormal movement, torsional movement at his neck, at his shoulder, and he can keep his head straight ahead. You can see that in this video. Yeah, he can keep his straight ahead, and he's only use his hand to touch it to keep his head straight just a little bit to improve that abnormal movement. Okay, we will come back later to analyze those abnormal movement later. And the patient have, with the examination like that, the patient have a diagnosis with cervical dystonia, and he also takes the blood examination and the brain MRI and the cervical MRI, but no abnormalities were discovered. Therefore, he has indication for the botulinum toxin injections for the cervical dystonia because of he has no response to the other medication before and rehabilitation. And moreover, the botulinum toxin injections have the level A indication for treating of the cervical dystonia. And we will come back for the botulinum toxin injections for cervical dystonia. And we have only 3 steps. In my summary, we have 3 steps for treatment of the cervical dystonia. Firstly, we will have the muscle selection, and secondly, we have the acknowledgement about the anatomy of the cervical muscle before injections, and thirdly, we will decide the dose of botulinum toxin, and we will come back first with the muscle selection. And based on the abnormal movement of his head, usually the observation of the patient at the firstly, and we will analyze the head position for the muscle selection. Moreover, we can use the palpate of the muscle of the head and the neck to searching for the hypertrophy of the muscle, for searching the muscle injections. Moreover, when the patient feeling the pain of the point of that patient feel pain can help us to localize the muscle also. And lastly, electromyography and ultrasound under guidance can help us to searching for the muscle abnormalities. And And in the clinical examination, the head position analysis under the observation is usually the most and the first approach for the muscle selection for botulinum toxin. And we will come back. In this case, can you show me some analysis about the head position, the abnormality? Can you help me? Yeah, anyone can show us in this situation about the head position analysis before we choosing the muscle. Okay, don't be shy. Okay, anyone has an idea about the abnormal posture of this patient?
Okay, I think in this patient, his head turned to the left, and his shoulder, the left shoulder is elevated.
Yeah, that's good. Yeah, anything else? Torsional movement of his head and his neck to the left, and his left shoulder might elevated. Yeah.
This patient have many positions of this the cervical dystonia. You can see the patient also have the tilt the head to your left, and shift the neck to your right.
Yes.
And also you also see the patient have a little bit enterocarpus. Of course, the position you say, I think this patient have 1, 2, 3, 4, 5 carpus position.
Yes, it's about the complex dystonia of this case because the patient has many abnormal positions, like Dr. Tai has explained. But the main position of the head position of these patients usually the torsional, the main position, and therefore I will choose the torsional direction for analysis of this patient. And you will see here the patient usually have the torticollis because of the Adam. We usually have the torticollis or torticarpus using the C2 vertebra for this analysis. But we in clinical examination, I usually choose the Adam apple or the larynx and the sternal head of this bone. Therefore, then if there is any shape of the Adam's apple and the sternal head like this, therefore the patient has the torticollis. But in the other, otherwise, then when the Adam's apple and the sternal head is still on the line, the patient has more prominent of the torticollis or torticarpus in that situation. And therefore, in this patient, when we analyze between the sternum and the Adam's head, the patient had a little shift between those structures between Adam's apple and the sternal head. Therefore, the main position of this patient has the torticollis. But when we reserve the observation about the abnormal movement of the patient, we see that the main, although the patient has the torticollis, but the patient have the abnormal movement of his head also too. They also have his neck, not only on the neck, he also has also the abnormal movement of his neck, torsion of his head to the left also. Therefore, maybe the patient has the torticarpus in this situation too, and therefore before going to injections of the muscle for cervical dystonia, we also check for the muscle that innervate for the torticarpus too. Okay, back to the muscle commonly injected in the torticollis cervical dystonia. We usually approach the muscle with the splenius capitis or splenius cervicis, levator scapulae, or SEM trapezius or semi-spinal disc cavities and cervices, and according to you in this situation, which muscles should we choose in this situation? According to you. Yeah. Okay. According to you, which muscle should you choose in this situation? Okay. Any ideas?
Thank you so much for your presentations of the case.
Yeah.
In addition, in my opinion, these patients, even you think the patients have the major the symptoms mainly for the left torticollis, and
Yes.
also probably might be the combinations of the left torticaput.
Yeah.
But by doing these patients, I think that he have more components of the left shoulder elevation and
Yes.
also of the minor torticollis also in this position, because when he walking, you can see that his back of his head become like
Backward,
this.
yeah.
Yeah, so
Backward means,
these patients like become have a more of a involvement in many planes of the cervical dystonia in these patients. And I think that if patients have the left torticollis, most of the people they try to inject in either for the splenic cavities in the ipsilateral or the contralateral sternocleidomastoid muscle. But by this patient, he have the components of the left shoulder elevations also, and sometimes with occasional of the torticollis.
Yeah.
So in my opinion, I will prefer on the ipsilateral or splenic cavities first, and probably might be the additional low dose for the contralateral sternocleidomastoid muscle in these patients.
And how about the left muscle of left shoulder elevation?
Left shoulder elevation, I think sometimes we can minor injection with the spleen, with the semi-spinal cavities or cervices, and also with the trapezius muscle in the ipsilateral. That may be helpful.
Okay, we will check it during the EMG and needle insertion.
Thank you.
Thank you. Thank you so much. Okay, any other options in this situation? Yeah.
With reference to your criteria to assess head position, you mentioned that pain, very important.
Yeah.
You mentioned those hypertrophy of muscles. But one criterion that must be included is the presence of tremor. Because if there is tremor, it tells you which muscle to really target. Because the best muscle to target in tremor is OCI. So that must be one criterion to be included in the assessment of cervical dystonia.
Yeah.
The other point is the null point. When you have a patient with cervical dystonia and they go this way, you have to let them move to the opposite side. Okay? And you can see that when they move to the opposite side, they go back to the original dystonia, and once they go back to it, that is your null point. And that is where you should be more targeted in choosing your muscles, when you have your null point.
Yes, thank you, Dr. Rosales. Okay, I will totally agree.
Hey.
Yeah.
About the tremor, I just want to make a comment. Normally, if you have the patient have tremor, you take off the patient, they visit the hand to the dominant position. And that's something I published about 30 years ago, but it only forgotten because at the time the terminology is not clear. I choose the wrong one. I call it bidirectional torticollis, which is wrong. But that help you. The patient have the eye gives them the direction. So that when it pull, they fight back, pull, fight back, pull, fight back. Tremor would be pull, 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 pull. So if you ask that, if you take off the light, okay, they can correct it anymore, or they close the eye, they will go to this direction. That's why you choose.
Okay. Thank you so much for that.
It was recently indicted. So no, not indicted. I was furious. It never gets cited. So I finally edit the patient issue on tremor so I can make people cited. Thank you.
Okay. Thank you so much. Okay, we go moving back to our case. And the patient was evaluation the severity of the cervical dystonia with the TWS-TRS scale. And you can see the torticollis severity scale were prominent with the 23 points, and the total points of the severities was 37. The patient showed no pain during those abnormalities. And before we inject to the cervical dystonia, we will know the most important for treatment of the torticollis. I will show you previously. Predominantly, we will choose the SCM splenitis capitis or the semi-spinalis capitis. Some of the other situation, the levator scapulae will be the muscle will be selected in some the torsional and elevation the muscle. Torsional and elevate the scapulae. And one more muscle that Prof. Rosales will mention about the OCI. That means in the deep structure muscle of the head. We usually approach this muscle in case the patient had a head tremor dystonia. Head tremor, usually we approach the OCI. And in some case of the torsional cervical dystonia, there has no response with the previous muscle. And at that time, we will approach the OCI in that situation. And how about the deciding the dose and in the cervical dystonia, we usually base the dose of the treatment of the cervical dystonia usually based on the severity of the cervical dystonia, and sometimes the muscle hypertrophy or the muscle pain, and we will notice about to adjust the dose of that muscle. However, in some patients we have the well respond to the previous cervical dystonia, we can base on it for the dose of treating. However, in one notice about in the newly diagnosis of cervical dystonia treatment, we usually use a lower dose, usually initiated. At my center, we usually treat the patient with cervical dystonia with upper botulinum toxin. Therefore, we usually choose about 400 unit for the female patient and 500 units for the male patient. And here is the sum of the recommendation dose for the treating of cervical dystonia. And in this patient, as we mentioned previously, the patient had the predominantly they have the left torticollis and the left shoulder elevation. Therefore, we usually start to examine and injections with the right SCM, the left splenitis capitis, and because of the patient had a left shoulder elevation, therefore we also check for the left levator scapulae. And the first we check the SCM muscle, and with the ultrasound and the EMG, we can see some the muscle, when the muscle injected in the SCM muscle, and we found some muscle activation in the EMG. Therefore, we check injections of botulinum toxin in the SCM. And the next, we check levator scapulae injection, and they also has the muscle activity on the EMG. Therefore, we choosing the dose and injection also the dose of the levator scapulae too. But when we check the scapular splenitis capitis, the muscle too high, too tight on the muscle ultrasound. Therefore, we usually the hyperactivity in the EMG. Therefore, we choosing the more doses. We choose more doses in splenitis capitis, and we also check the OCI injection and the hypertrophy of the OCI. I'm so sorry because of the screen of the ultrasound to fade. Therefore, we cannot see the OCI in this screen. But the OCI still is a deep structure of the head, and we usually insert the needle at about 3 to 3.5 centimeter from the surface of the head. And there's two types of OCI injections for approach. previously we usually the in a plan technique to prevent to touching the vertebral artery. But nowadays we use at my center we use our plan technique. Our plan technique before the shorter of the needle insertion in this technique, and we easier to approach the OCI muscle. And this patient, here is the dose of my patient when choosing at the first time, and because at the first time for cervical dystonia with the levator scapulae 100 unit, splenic cavities we use the 230 units, and right SEM for the 120 unit, and the OCI left OCI we use 100 unit in this situation. And after 1 month of treatment, the patient show improvement on his abnormal movement of his head. He can keep his head straight ahead within 1 minute. Within 1 minute, but and no adverse effect to recognize at this situation. We can compare the before and after treatment of this patient. The patient has a good response to botulinum toxin injection in this situation. And the TWS TRS scale show the remarkable improvement on this scale. And for closing remarks, I will remind all of you about the anatomical knowledge about the on the muscle of the head and the neck before approach injections of this muscle. And the concave concept nowadays we usually use it to distinguish the abnormal movement of the head and neck, and therefore we can have the muscle selection appropriate in this situation. And in the muscle injections of the head and the neck, the EMG and ultrasound guidance is one of the more very useful to locate the muscle targeted. You can use EMG alone or ultrasound alone, or in some center in combination of the EMG and ultrasound is so good in this situation. And for the newly diagnosed and treatment with cervical dystonia, we advise you to use the lowest dose as possible, and we wait for the response of the situation. In some cases, there's no response in the botulinum toxin injection, we can try again with the higher dose or the other muscle selection for the better outcome of the patient. And thank you so much for your attention.